the Constitution is silent on who should handle human resource for health. The Constitution of Kenya is beautiful. I mean, Dr. Wangari, it's...
I hear it's one of the best.
Yes. And there are so many... And
I
there are so
hear
many...
because, okay,
There are so
carry on.
many bits that we are yet to fully implement. I mean, now that I'm hearing clamor for constitutional amendment, I'm wondering, what do you guys want to do? You want to spoil the whole thing? It's possible to do this. Bring on board a health service commission, or even just, solve these problems without changing
The Constitution.
It is possible. We don't need to chart that document right now.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a Blue Cross and a Green Cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more?
Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast.
My name is Dr. Diana Wangari Gitau, and welcome to season 2 of the One Health Lens podcast.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making it simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitau.
And I am Dr. Simon Moshara Kigondu.
We had a very interesting conversation a week or two ago around the legal elements and breaking it down. What was the High Court ruling that said 3 of the UHC acts are unconstitutional? And we had a very important guest who broke it down for us, and we're like, this is why this ruling was made. And we want to have a follow-up conversation around healthcare, and I think it's some legal elements that have been brought to light. And I'll let the guest introduce herself, then we'll get going.
Hello, guys. My name is still Margaret Nyambura.
It is?
Yes.
Yes.
A health lawyer, and as usual, I'm happy to be here.
Absolutely. So last time, as you're leaving, and I know we rushed you and we're like, no, time. I think one of the things you mentioned was tribunal or dispute tribunal, and that is still hanging in there, right? So maybe start off by, what's a dispute tribunal? How does it relate to healthcare? What is hanging in there? Go.
Great. So one of the creatures or one of the institutions that was formed under the Social Health Insurance Act 2023 is the Social Health Insurance Dispute Resolution Tribunal. So the purpose of this tribunal is to resolve any issues that arise from the implementation of the Act. If any activities are supposed to be performed, if any services are supposed to be offered under the Act and they are not offered, there needs to be a way to adjudicate over any dispute that arises from the environment that is going to be created by the Social Health Insurance Act. So for this reason, a special tribunal was formed under the Act. We are waiting to see the formation because the function of recruiting of members all the way from chairperson, secretary for the secretariat, and the membership lies with the Judicial Service Commission. So this is the point at which the two arms of government come together. Judiciary, which is responsible for interpretation of the constitution and also just resolution of disputes, comes together with the executive arm, the Ministry of Health, for purposes of this conversation, and you have a specialized disputes tribunal. So you will see how are they special, the unique requirements from all the way from the chairperson to every member of the tribunal is going to be spelled out in such a way that the Judicial Service Commission is going to be outsourced to recruit the personnel for purposes of execution of the functions for the Ministry of Health, right? So any act under the law that you may think of, empanelment of service providers, contracting of those empaneled service providers, the registration of members, pre-authorization of registered members as well. We are seeing the tribunal as the one-stop shop where you stop over for a while to try and resolve any disputes, to adjudicate over any conflicts as well. So as with all other places or all other avenues where there is dispute resolution, this tribunal is also going to be prioritizing alternative dispute resolution. What do I mean by that? Negotiation, mediation, arbitration in places where you have contracts and the contracts provide for arbitration as the means or the method through which conflicts are going to be resolved. So any of those areas, if an issue arises, the first place to stop would be the disputes tribunal. So we usually have this principle where you have got to exhaust local mechanisms before you step into high court or any other higher court in the hierarchy of the judicial system. So even with this case, you first of all stop over at the dispute resolution tribunal. If you are disgruntled with a decision or there is an issue of national concern, as I'm sure there will be so many, because this is a novel area, there are going to be so many teething problems, you stop over there first. Then if you need to get appeal, you go to the high court. So at the high court, that's where we expect to be the close of any issues. Things should be fully settled by that point. But should there arise a specific issue that distinguishes itself as being a thorn in the flesh or something that needs to really be figured out, then an appeal can always lie to a higher court, sort of for instance, the Court of Appeal. And if it doesn't stop there because there is a particular question that has been singled out as being problematic, it goes to the highest court in the land, which is the Supreme Court. Now, one thing that I would be keen to mention is also that this tribunal also has the capacity to give an interim relief. What do I mean by an interim relief? There is the provision that the tribunal should have fully settled a matter within 6 months. But if, for instance, Dr. Wangari, today you walk into Avenue, sorry for just an example, you walk into Avenue Hospital and you're told that there's an issue with your pre-authorization, you should be able to get Nyambura here to go to the tribunal quickly to file a matter under certificate of urgency, and you're able to get an interim relief. And after that, there's going to be the full settlement of the matter. And then now, if the interim relief was deserving, it's going to continue being in place. If it is found to have been non-deserving, it's also going to be determined by the court. Now, we are waiting for the rules to be gazetted because they have not yet been gazetted, because we need to know what documents we are going to be using, and also just other small unique issues that usually surround administration of justice. So we are waiting to see that set of special legislation. The other thing I would also like to mention is that sometimes when you have a disputes tribunal like that, there might be conflicting positions taken by the members of the tribunal. So for instance, we are looking at the issue of again pre-authorization for you to get services at Avenue Healthcare. A majority is going to carry the day as usual. Sometimes, most often than not, if it is a question just of pre-authorization and the facts are clear, and the disputes was simply from, let's say, records which were off or people who did not have adequate information, then there is usually a common understanding between all members, right? So that all of them are in unison, and the decision stands. Now, the decisions are going to be signed by the chairperson and in case there are any orders that you need to also certify, because sometimes I know, for purposes of the people who are listening to this podcast, a day is coming when someone is going to be seeking a certified order from the tribunal. It's supposed to be certified by the chairperson or the secretary of the secretariat for the tribunal. So I'd like to close that at that point, and I'll be open to receiving any questions through you guys that come through as soon as the Social Insurance Dispute Resolution Tribunal is set up.
I mean, it's such a critical unit because, as you said, right, it's a novel thing, right? If Social Health Authority goes through and all relating to it, people, of course, are going to stumble here and there, and you expect that people are going to have issues, right? Kigondo, as far as this tribunal goes, what are your thoughts?
So I think she has put it extremely well. Having discussed with her on the issues of the tribunal, the first thing is that the thought of a tribunal is a good thing because with NHIF, who are the judge, the jury, the executor, there was actually no place to actually go and report NHIF, and that's the reason we still have unpaid debts today. We still have government saying this, provider saying that, and there's nowhere to adjudicate that. So the concept of it is excellent, and I think what we are saying going forward, there needs to be more active public participation, including with a legal team, and of course all health care specialists and lawyers and things like that. So the tribunal is a good thing in principle, because now we'll have somewhere where you can send your complaints, but now it needs to be really thought through and through on how these claims will be filed, lodged, and what the solutions are, what they constitute, and which people are in the tribunal. They've listed a few, of course. We'll always have something to say about the composition of
naturally
people in the tribunal, but it's a good idea.
Okay, I mean, maybe let's pick one thorny issue that's always human resource for health, right? Because there's been a lot of movement even on that front, right? And I'm not talking about strike. I'm talking about, say, there's been mention of one, there's the Health Service Commission, but there's a task force, right? That was, what happened? It was formed, right? Maybe first Kigondu, before we go back to Nyambura, maybe just walk us through what was the task force that was formed and how is it different from the Kenya Human Resource, there's KHRAC, right? What is KHRAC? Just the name, and we'll get to a fuller here one day again. But walk us through the task force and what it entails, then we'll rope in Nyambura to hear her thoughts.
Yeah. So thank you. So from the constitution making process of 2004 onwards, there was those, you remember those Bomas drafts and things like that. We as health workers and health personnel have always thought that a unified body managing health personnel is a good way to actually ensure that you have uniformity, fairness, and things that are. So prior to devolution, let's say, all civil servants, so to speak, including health workers, were managed by the Public Service Commission. And when we were going into the new constitutional dispensation, we actually were thinking that it is a Public Service Commission. The health people will move to a Health Service Commission. And of course, there was a Health Service Commission inserted in the Constitution that was just relegated to an act of parliament when the Constitution was passed. You can read about that. So the functions of a Health Service Commission would include to register trained health workers, recruit and employ health workers, assign health workers employed by the commission for services any public hospital. Note, this is different from the TSC. Any public hospital and health facility, promote and transfer health workers according to service need. Of course, not arbitrarily. A lot of the things people fear is that, we will be arbitrarily transferred. Of course not. To exercise disciplinary control over health workers employed by the commission and to terminate employment of health workers in the health service. So that's the general principle. So some of the issues that were brought about by devolution was that you are fixed in a place. If you wanted to move from one place to another, you can't move. I give my example. As in the Public Service Commission side, I moved from Kenyatta University of Nairobi to Machakos, back to University of Nairobi, still under the Public Service Commission, to Isiolo District Hospital, to Murang'a County Hospital. Now I'm in Murang'a County, I can't move. Because if I need to move anywhere else, I need to quit. They tried, and Nyambura will explain to put some intergovernmental things that don't work. Yeah. So if there was a Health Service Commission, then I would simply say that if I wanted to move to a place and someone from that place wanted to move to my place, they would come. And you just swap, you get, without that. So the devolution of health stopped a lot of things in management of human resources, in that you'll find that people in one area, one county, that maybe there's a good governor, there are good health policies, benefit more than people in another area where now they are suffering, and at the end of the day, the mwananchi suffers. So what you are saying, uniformity and sort of fairness and ability to transpose health is a national issue. So then came a middle ground, and if you remember that, we made presentations to the Kenya Kwanza government prior to them coming into government, and we of course proposed the Health Service Commission. But when they came in 2017, the Health Act, and Nyambura can attach that, a Kenya Health Human Resources Advisory Council, yes, sorry. Okay. Council was created, KHHRAC, you see. And it had all functions of the Health Service Commission, except that it was advisory. County governments can take or not take the issue. So between 2017 and 2022, really it was there, but sort of not too much effect. When the Kenya Kwanza government came in, they actually sort of gave it teeth. And you saw there was appointment of people and sort of operationalization of the same. But at the same time, it was still advisory. And it may not necessarily solve the issues. The problem, and the classic example, is the interns. The KHRAC work plan has, we will sort the interns, we will post them quickly, and they did nothing when interns were suffering. You get, and that's the advisory nature of it. But to their credit, on October 18th, they launched the Kericho Declaration, and it's fantastic. If they actually did what they said in the Kericho Declaration, then it's fantastic. And then what Nyambura will finish with is, maybe because the commission, people seem to be very allergic to it, maybe KHHRAC can made to do what the functions we are talking about, give it a bit of teeth and finances and empowerment to do that. And one of the ways in part of the Kericho Declaration was to make it a SAGA, which is a semi-autonomous government authority, and maybe it'll have more power along that. So Nyambura can comment on all this. This task force that they formed was the wrong task force. In the return to work formula that the KMPDU signed, the task force was supposed to look at health, not human resources for health, because we already have KHHRAC. And there is nothing different that the task force is doing that KHHRAC had not already planned to do. And they've even allocated some money to it, which in my view, I won't tell you how much, in my view, should go to KHHRAC to actually strengthen the plans that they have for improvement of human resources for health. And of course, as we have said, there is an aspect of it that can be made into a Health Service Commission function. You know, let's remove the word because people are allergic to it. And finally, when I was discussing with Nyambura, one of the issues that she brought up, and it has brought new light to why that devolution of health is unclear, is that in the scheduling, there is no specific mention of human resources for health. And she explains it very well, and I think she will. What the devolution devolved were facilities. And it was then assumed that the human resources are in facilities. So I think, and what we have learned is that being explicit is very important. There is actually no explicit mention of human resources in devolution. So the schedules do not say doctors will be under county government, doctors will be under national. No, it said level 1, 2, 3, and the assumption is that the personnel
will follow the facilities.
And therefore, I think yes, going into the future, we need to be more explicit. But I think with that, I think Nyambura can take over from that and give a running commentary towards the end.
I mean, it's a thorny issue, right? It's, as Kigondu says, it's something definitely he's been passionate about, Health Service Commission. But let's remove that. Let's focus on the functionality, right? So from your perspective, one, responding to what he said, but then supporting it from a legal perspective. What's feasible? What do you foresee as potential not stumbling blocks, but things we need to look out for, right? Because not for the first time, but we have KHRAC, right? Which potentially could encompass this functionality, right? But then it seems like, as Kigondu is saying, it is at this point in time advisory, right? But if you were to empower it to be, this word empowerment, but if you were to support it from a legal perspective, what do we need to look at? What have you seen? What have you seen?
Okay, great. So thanks for the context, Dr. Kigondu. As always, the historical understanding is usually very helpful for new guys like me. I don't know what I mentioned last time. I've only been 4 years actively...
in health.
No, actually in health, much longer, since my internship days.
Yes.
I had a short stint at the HIV/AIDS tribunal by there as a student, now that I'm remembering. Anyway, back to this conversation. So Dr. Kigondu has mentioned that the constitution is silent on who should handle human resource for health. The constitution of Kenya is beautiful. I mean, Dr. Wangari, it's...
I hear it's one of the best.
Yes. And there are so many... And there's so many...
because, okay,
there's so many bits that we are yet to fully implement. I mean, now that I'm hearing clamor for constitutional amendment, I'm wondering, what do you guys want to do? You want to spoil the whole thing? It's possible to do this. Bring on board a health service commission, or even just, solve these problems without changing
the constitution.
It is possible. We don't need to chart that document right now. Anyway, having said that, semi-autonomous government authority. You said it's called a saga. Yes, so that's what I would call an independent commission. We have got a whole chapter in the constitution that provides for those. That's where TSC is. That's where the Kenya Human Rights is also there. We have got IBC, it's also there. So we could bring it there, not now though. Maybe after KHRAC grows up, after it's done its job and it grows up, and we realize that it no longer is able to perform its mandate as provided for in the Health Act of 2017, and you need it to have, to grow extra pair of legs, extra pair of hands, then we can slowly grow it into a commission, right? But as far as we are concerned, we can start forming new task forces and new bodies, and maybe not even get to the point of the commission yet before you have properly enabled KHRAC to perform its mandate, right? So I think it's just sometime last year after President Ruto came into power that it was properly constituted, and I think I saw some PR on the setup, the guys coming together. I think it's headed by Professor Wafula, a couple of other guys. I don't remember who they are. Then the 56-day strike came this year, and they were silent. And as far as their mandate goes in sections 30 and 31 of the Health Act, they are supposed to have been the ones guiding, or at least orienting, the resolution of that dispute.
Correct.
Their mandate does not only stop at, coordinating specialists and moving them around between counties or between two levels of government. It goes beyond that. In fact, interns sit squarely within the boundaries of what they are supposed to be doing, right? But they were quiet. I don't know why. We haven't had them speak. So the question I was asking is, are they budgeted for? Have they received a budgetary allocation to enable them set up a secretariat, run their operations? Do they have a registered office so that Kenyans can knock on the door and say, oh yeah, this is where the advisory council is supposed to be? What do interns do? They go and camp outside a fair house, right? Whereas there is a body that has been created under the Kenya Health Act of 2017 to provide for all these concerns. So thank God for the judiciary, and thank God for the function that it can perform. There was a petition that was filed by the Law Society of Kenya questioning the task force that was created under presidential number 5 of 2024. It's the one creating the specific task force as a result of the return to work formula that was negotiated by KMPDU and both levels of government. Both levels of government, because remember, health human resource is not specifically assigned one team, but the constitution cannot really cover everything. It can give guidance, but when some rules of interpretation according to law usually suggest that some things fall in the same class, and therefore you can assume that if you say tomatoes, onions, garlic, then any other vegetable would fit there. Others say if you wanted a tomato to be there because it is also a fruit and a vegetable, then you would have mentioned it. So we are mostly inclining towards the one that says that if you wanted something to be expressed, you should have explicitly stated it. So Ministry of Health, as far as the Schedule 4 is concerned, policy work. Primary health care is licensing of funeral parlors and a couple other things is placed under county government. Health human resource hangs in the balance, and therefore it is jeopardized. So what happens? Everybody grabs a chunk of it. So I have made this allegory before, and it's a joke, but I feel like it closely fits the evolution in healthcare in Kenya. Are you familiar with Humpty Dumpty, the nursery rhyme?
Yeah.
So Humpty Dumpty sat on a wall. So Humpty Dumpty is the health function. And then it had a great fall because we thought Schedule 4 is going to properly hold it. But looks like the base of the wall that Humpty Dumpty sat on was not good enough, and therefore the health service, the health force, or rather the health function falls. And now the king's horses and the king's men in this case, who are trying to put Humpty Dumpty together again, is the national government and the county government, and we can't agree on who gets to handle what pieces, right? So again, you get to see that a return to work formula is signed by both county governments and national governments, and most of them, save for who gets to do what, other clauses are all copy and paste. But this is, so you have one for national government, and then you have 47 others for counties. Why? For what? Right?
That's signatory. It's pages of
Why? For what? So Law Society of Kenya goes to court. Just the other day, we got the order that is freezing the implementation of this task force. Professor Wafula, who chairs the KHH-RAC, also sits on this presidential task force, or rather was also assigned, or rather recruited or appointed to sit on this task force. Alongside some other key players, I think there's some administrators in private healthcare. There's a lawyer
distinguished people.
Yes, distinguished, right? So you are duplicating a function that already exists, yet the one which exists has not been properly financed to do so. How about we allow them, give them the budgetary allocation, set them up, let them perform their mandate. In case there are any shortfalls, let's check in with them, as opposed to forming a parallel body that is also going to be fleecing Kenya, or rather it's another outlet for money.
For revenue.
Yet the president the other day just said that we are broke.
Tighten our belts.
Yes.
Live within our means.
Happen apparently, right? So so how about we just finance? Can we just finance the KHH-RAC? And then maybe it can slowly grow into a health service commission. Once one day we get there and we figure out that these guys have bust their banks, right? Health workforce. And you remember, there is the unique question of, is it going to be like TSC or PSC? It can't be now, because one thing that we need to mention is that the Kenya Health Act mentions explicitly that under the mandate of the KHH-RAC, that one of the roles it's supposed to perform is to look into health human resource without leaving out county governments. So the Health Act acknowledges that the function is supposed to be shared, right? So county governments are also supposed to be taken into consideration, because they're also going to be appointing bodies for some of these health resources. So the other thing I can probably mention is that we have seen this pattern before. And this was when previous President Uhuru, when he was leaving office, he also made a presidential...
this is the producer telling us.
Presidential
yes.
Oh, okay.
Kyron.
Yes. So there was also President Uhuru with the Tissues Transplant Authority again. So Constitution was quiet on what to do with blood transfusion, tissues, organs, transplants. And I remember when we were transitioning from previous Constitution to the now Constitution, neither of the neither of the levels of government took up that function, and it was also hanging in the balance. So because it is hanging in the balance and there is a lot of crime around it, the president assigns it an authority without checking in with the county governments. Now, some people have previously said that the tussle is for resources, because once you tell Dr. Kigondo is going to be sweeping this studio, you also need to pay him to do that. But if you tell him not to, then he doesn't get to be paid. So if you tell the county governments that they're not going to be handling blood transfusion, tissues, organs, transplants, then it means you're also not going to allow them to hold on to the money that comes out of the offering of that service, right? Some people will purely look at it from that angle, but I like to look at it also from this other angle, that tissues, transplants, organs, these things don't exist on their own. They are somewhere in the middle of offering services. So how am I supposed to be offering services, yet the things which allow me to offer services are in the hands of another external authority? Don't you think I need to participate in the decision making on how to deal with this? I don't want to call them organs of trade, because then the pun is going to be intended. But how am I going to,
absolutely
give the service without having an influence, or at least participating in the function of how to transfuse, how the blood is held, how it moves around, right?
I mean, there's a lot, huh? That's why we are having still Nyambura to come back again. Because, I mean, I like one part I've had that perhaps could be our running series of dear incoming CS or dear new CS, as the case might be, is that let's stop duplicating efforts. There's already KHRAC, which is there, which potentially could start from here and grow into, right, independent commission, as the case might be. It doesn't have to be called Health Service Commission, but functionality could cover a few of those, right? So we stop duplicating effort. We support, finance, structure it in a way that it is a body that's recognized to coordinate not just different elements of human resource, but it can be a go-to that then we start finding a way forward to some of the issues we've been having. Yeah? Kigondo, we're good?
Yeah, I think we're good. And finally, I think people need to move out of the idea that when you have a health service commission or a body that coordinates things, it takes away the powers of the county public service boards to employ. They can actually, we go back to the Nairobi County, which had its own employees plus the county government, and both worked, for instance, in a health institution. So that dichotomy is what people need to move away. So the county governors can still employ their people.
Okay, they are middle grounds. We just need to keep talking about it so that people understand where every party is coming from. Remember, it seems you're coming back again because Maina's told us it's time. Thank you so much.
Thanks for having me.
Sawa. Thank you so much for joining the One Health Lens podcast, and we'll see you next time.